Okay, well, welcome everybody to the meeting. I don't think I've got any apologies, have we, for absence?
We've got quite a few apologies, actually. We've got Isabel, Graham Bridgman, John Barrett, Roz Crowther, Natasha Pantalik, and Natasha Berthollier, and Tom O'Kane.
All right. There we are.
They were on your other screen, weren't they? They were on the other screen, weren't
they? They were. Okay, declarations of interest, anyone? No. Okay, minutes of the last formal meeting, the Council of Governors, 4.1. Any corrections to the minutes, please? No, I've seen people shout if they... any matters arising that people I don't think there are any noted, but no. Okay. If we get on then to item 5 and welcome Chris Randall, who I hope is somewhat online. Are you here, Chris?
Yes, I'm here. Thanks, Chair.
Thanks so much. Who's going to who's from our external auditors, Deloitte's the report to the Council of Governors. There's a paper in the pack, but Chris, I'll leave it to you to talk us through.
Excellent. Thank you very much. Would it help anyone if I were to share my screen so that it can be on screen for the meeting? Okay. Or does everyone have it available with them?
We've all got it, but if you want to do it, it doesn't matter, as long as it works.
I shall try and share my screen now. Let me know if it doesn't work.
Yeah, we got it.
Are you able to see that? Excellent. Yeah. Okay. So I will generally take the report as read and go through and pick out the highlights. If anyone does have any questions as I go through, feel free to ask though. So this first page sets out the key messages. So I think modify, and in terms of value for money.
Chris, we're losing your sound.
Oh, sorry. Is that any better?
Yeah, it sort of breaks up.
Let me if it falls apart again, I will try and I'll different sort that out. Okay. So overall, our audit opinion was unmodified, and in terms of our work for VFM, the arrangements in respect of financial sustainability were as expected. We did note that various changes had been made to the processes for assessing financial and performance information in response to the pandemic, and these were again appropriate in the context of the environment in which the trust has been operating in the past year. Note that as the trust plays an active part in 2 integrated care systems, this does make things slightly more complex regarding governance, but the arrangements that are in place at the moment are appropriate for where the trust is in those systems. We move on to the next page, the purpose of our report. So this report brings together both our audit work and our work on value for money. Our work in respect to value for money focuses on the 3 E's, being the arrangements to secure economy, efficiency and effectiveness. And our work is based on the assessment of the adequacy of the measures that the trust has in place based on our risk assessment. As an important caveat, we don't consider the adequacy of every single arrangement that the trust has in place, and our work doesn't provide positive assurance that the VFM is being delivered. From our work, we have not identified any significant weaknesses to bring to your attention, which is definitely a good result. The next page essentially brings together, sets out the assurance provided by the external audit function and how this fits into the overall assurance processes at the trust. Once again, I'm not going to go through this in detail, but I'm happy to take any questions at the end on this. Moving on, our next page sets out our opinion on the financial statements and the work we did as part of our audit. As I said before, our audit opinion was unmodified, and this page also sets out the other areas that we consider as part of our audit. as well as the financial statement. So I'll work on the remuneration and staff report, I'll work on the annual governance statement, I'll work on the annual report, and our reporting to the group auditor, in this case, the National Audit Office, as well. I move on to the next page, which sets out our financial statement audit approach. So our work is planned and performed to detect misstatements which would be considered to be material to the trust. We define materiality in this instance as 5.3 million, which is based on the level of income for the Foundation Trust. We reported all uncorrected misstatements in excess of £265,000 to the Audit Committee. And materiality and our approach to calculating it was broadly consistent with what we have used previously in relation to our audits. We set out on this page our broader approach to the audit as well, and once again I'll take this as read unless there are any further questions.
Okay, Chris, so you're happy to take questions?
Yeah, happy to take questions at this stage.
Over to governors, any questions? Paul?
Yes, Chris, thanks for this. Just one question. I mean, we as governors, some of us probably read this in detail and feel a bit responsible. Some of us just gloss over it. But I'm wondering who actually sees this apart from people in the trust and the governors. Is this sent to NHS England, for example?
So this report itself isn't sent to NHS England. What we do, we don't report directly into NHS England. However, we do report into the National Audit Office, who are essentially the auditors for the NHS overall. So we report into them as a component of that wider audit. What they receive is obviously our audit report. We have a separate reporting that goes to them on whether we've identified any significant issues and whether we've identified anything in particular in relation to our significant audit risks. And we also send them our final report to the Audit Committee, so they also see that. But this report itself doesn't go to NHS England, and we also don't report anything directly into NHS England.
Okay, thanks. So it's the National Audit Office who really holds the trust to account through the audit report.
From a sort of national basis, yes. I think to a certain extent, it's mostly us who will be looking at the trust itself, as obviously the National Audit Office will be looking at the NHS overall. But in terms of a sort of centralised reporting, we do report into the National Audit Office, and if they did have any queries on what we were doing in the audit or any of our findings, they would then reach out to us.
Okay, Tom.
Yes, just to say, from the point of view of the casual reader or inexpert reader like some of us, it would be very helpful if the recommendations were collected together rather than being scattered throughout. So it's a bit of a not made very easy for us. And thinking about the recommendation on PFI, I wonder if you could say a little bit more about the implications of PFI coming to an end, sort of early termination of PFIs.
Oh yes, I was going to come on to that later if that's okay.
Yeah,
okay.
That's fine. Yes.
Okay, and Chris, back to you.
Thank you very much. So if I continue going through our report, so the next page sets out our work on our identified significant audit risks. There were 3 of these in relation to this trust. So they were property valuations, the validity of accruals, provisions and deferred income, and management override of controls, the latter of which is a presumed significant risks on all audits under auditing standards. So we set out on these 2 pages the work that we performed in relation to each risk and the findings thereof, of which there were very few. So there were a number of low priority control observations in relation to our work on accruals. Otherwise, the work was as we would expect, and there was nothing to report to the Audit Committee, and there's nothing significant to bring to your attention either.
Okay, Chris.
Sorry.
The press on, I think, for the moment.
Okay, excellent. If we then move on to the section of our report that talks more to our work on value for money arrangements, this first page here gives an overview of the background of our work in relation to value for money and the procedures that we perform in response to it. So we consider value for money under 3 key areas, being financial sustainability, that is how the body plans and manages its resources to ensure it can continue to deliver its services in the longer term. Governance, that is how the body makes decisions and manages risks. And improving economy, efficiency and effectiveness, and that is how the body uses information about its costs and performance to improve the way it manages and delivers its services. So if we move on to the first area, which is financial sustainability. So we set out here our work in relation to this. So we note the trust recorded a surplus for the year and had a relatively strong net current asset position as at year end. We know the planning process for the 2021-2022 financial year was at an early stage as at our reporting date, but this was consistent with the sector as a whole and is as a result of the pressures that have been put on the sector by COVID-19. We also note that there are adequate processes in place to monitor financial performance. We do have one insight here, which is in relation to PFI, where the contracts are due to expire in 2033. So as you approach the end of those contracts, the trust will need to consider whether any changes are needed in the existing monitoring processes to ensure that VFM, that value for money, is achieved in exiting these contracts. So I know we had a question in relation to this earlier and sort of specifically what this would mean. So I think the key thing here is obviously when the agreements end, there will be various decisions to be made around how the assets are then managed and what the contractual arrangement is after that. I think at this stage there's nothing significant to be aware of, but I think it's more just to raise it as something to have on the radar, that obviously when the contract ends, it needs to be considered how best to manage the relationship and manage those assets going forward. Did that answer the question, or was there anything further that needed to be addressed there?
Tom, you're happy?
Well, just to say, my impression is that I don't know if this is right, you might be able to answer this, but the flexibility of use, when we're changing, any changes made in major or minor at Prospect Park Hospital, for example, that involve a certain amount of negotiation and perhaps expense. And I wonder if this could be made much easier, quite apart from the direct financial considerations, when the PFI contract in its current form comes to an end.
Tom, I don't know if Julian wants to I imagine absolutely everybody, when this falls off the PFI company's balance sheet and onto ours, I'm sure that everyone will breathe a huge sigh of relief. I expect that the overall cost of running the place, which is obviously passed on to us through the PFI charges, will reduce, and that the timeliness of everything will be at the pace that Berkshire Healthcare Trust dictates, rather than having to negotiate with a third party. It's obviously very complicated. I mean, from time to time, government considers, how can we best. PFI was a device for keeping things off the national balance sheet, and there's no point in denying that. And from time to time, people do flirt with the concept of, making cost savings and doing things early. And the sort of points that Chris made and that you made are clearly very relevant to whether, should we say, early terminations and all of those sorts of things should be considered. But at the natural end of this, I am sure that Julian, even though he'll be 104 at the time, if he's still around, he will breathe a huge sigh of relief. Julian?
Yeah, that's it. I mean, Chris raises a good point. So just for in simple terms, morning everybody, by the way, Julian, Chief Exec. But just to say that at the moment, obviously we pay effectively a mortgage for the rent of the payment down on the building itself, and the facilities management, so the day-to-day, maintenance of buildings, the redesign of them, portering, domestic, cleaning, catering is all provided under the PFI contract by ISS. Come 2033, what Chris is saying is, when the building gets handed back to you, how do you want to be prepared for running that facility in the future? You'll need to have a plan, which is absolutely right. The beauty of it by 2033 or sooner, if we're able to pay it off, is that the building will be ours, and therefore there won't be the complicated legal stuff that's required of the changes in the PFI now. So that will be much easier. It'll just be about having a plan about how you actually implement those changes, which I think really is Chris's point, which is, you know, you can't just wait till it's handed over and then work that through. You'll probably need 5 years or so beforehand. You need to have a sensible plan about how you're going to run that hospital in the future. Changes themselves, though, Tom, far easier once it's in our total control.
Okay, Tom, you happy?
Yes, very happy. Thank you.
Thanks so much. Chris, do you want to press on then?
Yep, we'll do. So if we move on to the next page, so this sets out our findings in relation to governance. So as part of this, we noted that obviously the CQC in the last inspection rated the trust as outstanding in this area, as well as a number of other areas as well, and an overall outstanding report. We have noted that appropriate changes have been made in relation to governance as a result of COVID-19, with an increased focus on budgetary control. We also note that the head of internal audit opinion in this area was that there was an adequate and effective framework for risk management, governance and internal control. So once again, in this area, nothing significant to bring to your attention. And then if we move on to the final area, which is improving economy, efficiency and effectiveness. So in relation to these VFM arrangements, we again note that appropriate adaptations have been made in this area as a response to the pandemic. We note that the Trust does participate in 2 integrated care systems and has adequate arrangements regarding its participation in these and reporting anything relevant back to the board. We do have a recommend in this area that the Trust continues to monitor the arrangements in place as these systems evolve. They are very much, you know, something that at the moment is an area of evolution in the NHS, and it is something that is, you know, potentially moving from one reality to a potentially different reality. So I think the key thing is, as those arrangements evolve, ensuring that there is that the trust processes evolve with them, and that the board are kept informed of anything there, so that there can be proper monitoring of how those relationships are operating.
Okay, Chris, have you finished now?
I think so. I think the other page the other pages in the report are broadly they're appendices. I'm happy to take them as read. There's nothing to draw out from those. So yes, I'm happy to take any further questions on our report overall now.
Thank you, John Wellham.
Thanks, Chris. KPMG audit right across the nation with various organisations. Does our trust continue to be a leading benchmarker?
So it's always a difficult question to answer that. I think from my perspective, from some of the benchmarking that we do internally in Deloitte, I think Berkshire Healthcare does measure up very well. I think if you look at things like the CQC report, where Berkshire Healthcare is rated as outstanding, you know, that's certainly not something that you see across the sector as a whole, and that is certainly a very good feather in your cap. Likewise, if you look at the head of internal audit opinion, that was also a very strong opinion from them, and it goes to support the work that your management team are doing. I also think, from my own perspective, I think there are a number of other areas where I think Berkshire Healthcare stands up very well in terms of financial planning and delivery. Berkshire Healthcare, for the period where we've been auditing it, has always come in very close or has exceeded the budgets that have been set, and has also, in terms of cost improvement plans, has also had a very strong record of delivery in those areas. So I would say, it's difficult to say exactly where Berkshire Healthcare sits in terms of a national perspective, but I do think that it sits very well in terms of some of the areas that we look at.
Thanks.
Thank you, John. Okay, anything else for auditors? Thank you very much. I think, Chris, it's true, isn't it, if I recall, that there's a statement on the audit in the annual report and accounts. So there's just a brief statement of the auditor's opinions, and that goes to Parliament and is a public document. Chris, you had something? You're on mute, Chris.
Oh, it's the only way to shut me up sometimes. And just following a conversation I had with Paul at the start of the meeting, I think that given that that suggested it might be appropriate for the chair of the audit committee to respond. I would just like to put on record the thanks of Berkshire Healthcare Trust as an organisation, its audit committee, its council, for the hard work and professionalism that the Deloitte team has given over the 3 years of its statutory appointment period. Organisations can only deliver high quality governance if all of the sort of areas within the sort of the enlarged triangle of governance are performing at their highest level, whether that be the management team, the audit committee, the finance team, our internal auditors, counter fraud providers, and indeed our external auditors. And it's been my privilege to lead the audit committee when I think all of that team have been performing at the highest level. At a personal level, I'd just like to thank Chris and his colleagues. They've been sources of in an extraordinary period. They've been hugely important to the way that we have performed, and actually they've done it with a smile on their face. They're a friendly bunch too. And whilst I've always felt, should we say, under interrogation and under inspection, if you like, it's always been done in a very professional and helpful way. So, Chris, thank you so much for all your efforts over time, and good luck.
Thank you very much, Chris.
Thank you, Chris. And could I just take this opportunity? I was going to do it at the end, but I think I'll do it now, just to put on record. I'm sure the council wish to thank Chris for all the effort he's done, both as a NED and in particular on the audit committee. Chris, you've been a tower of strength in taking us through this. So thank you very much. I think the committee really is appreciative of what you've done, and we'll be all the better for it as a result. So many thanks, Chris.
Thank you.
Thanks.
Colleagues, with a minor adjustment to the agenda, if we may, because Heidi Ilsley, who's reporting on patient experience, has to leave for a COVID vaccination meeting before the time of her scheduled talk. So if you're happy, I was going to bring forward item 8.1 from Heidi to now, and that'll give Julian a little bit of time to think what he's going to say before his item 6. So if that's all right, can we invite Heidi to speak to her paper, which is item 8.
Thank you, Martin, and good morning, everyone. So really, I was sort of hoping the paper was taken as read, but just wanted to, just the main highlights really is that we had 59 formal complaints during Q1. 3 of these were related to COVID. We have had a noticeable increase in MP complaints. We are going to monitor this because it was a significant difference to the previous quarters. And just to let everyone know that our new internal survey, I Want Great Care, is going to be rolled out in October 2021, and a lot of work is going on about getting that ready and getting the training in place. And also to note that we did have an internal audit as part of the internal audit plan on the patient experience and on the patient experience process, and 2 of the sort of recommendations, although we came out green for everything, was about improving the capture of ethnicity data and in relation to taking a bit more of a deep dive analysis into services. So they're the main highlights, so happy to take any questions.
Heidi, I've got one actually on the carers and the new process for capturing patient's experience. So I'm looking at page 61. It says the patient experience measure tool does not include capturing carers' feedback. The specific card and methodologies, etc., will be used. Can you just say a little bit more about that? I was just slightly surprised that I must admit I hadn't noticed that carers' feedback was not formally part of the process. Can you?
Okay. So I have my training this afternoon, Martin, so I might not be able to answer it fully.
Okay.
However,
in which case.
However, we do have a new carers lead within the organisation, and they are going to be doing a lot of the work around capturing carers' feedback as well. So happy to feedback outside of that, but that's what I do know, that our carers lead is going to be taking the lead on that.
That's fine. I understand that. Tom.
Just to point out, sorry, it's very minor, but on the bottom of page 67 in the last item, the patient's name has been kept in, and perhaps this document should be updated to take it out.
Okay, thank you. We'll do that, Tom. Thank you for picking that up.
Okay, Andrew Horn.
Thank you. Can I take it to page 51, the ethnicity data that you mentioned? I was struck by the fact that the numbers of complaints are broadly comparable with the attendance in that quarter, apart from Black or Black British. Of course, these are very small numbers, but I'm wondering if this is backed up by any other data, because I understand this is a new introduction to the report, isn't it?
Yeah, it is a new introduction to the report, and we're also having to do further, more detailed data on this. So at the moment, there's nothing really to compare it to. We have had it in for a few months, but it's still very early days to be able to make too many comparisons. But it's certainly something we can monitor and will be monitoring, because that was something that was brought up in the internal audit as well.
Thank you.
Thank you, Andrew. Anything else for Heidi? Tom, is that another hand, Tom?
Yes, just to ask Heidi, just to follow up this ethnicity thing, the question is whether ethnicity is determined once and for all on the patient's record, or whether it's separately determined at attendance and at complaint. Is it part of a patient record, or is it something you add to a complaint?
Yeah, so the majority now are captured, ethnicity the majority is captured on Rio. Where it's not captured on Rio, that question is then asked, but we are normally able to take it from Rio now.
Yes, because if it's independent, of course, it makes these figures much less reliable. But if it's one datum, however, it's still being updated, you never know. But I think Andrew's right, there is some significance. There could well be some significance here anyway.
Yeah, and definitely one to watch. Thank you.
Thank you. Anything else? Heidi, just thank you very much. And it's good to see all the data and picking up the ethnicity one. I mean, now we're capturing this much more comprehensively. And we can see the trends as we go on. So that's really important stuff. Heidi, we'll let you get back to your vaccination programme.
Lovely. Thanks very much. Thank you.
Thank you very much. So that was inserted after item 5. I think if we now take item 6, the annual report and accounts, we invite the Chief Executive. And Julian, you might want to go on afterwards to the performance report, item 8.2, just to have a pack of things about performance. Over to you.
Okay. Yeah, I mean, the annual report. So good morning, everybody. Julian Ems, Chief Exec. Good morning. The annual report is, remember, a look back. So it's a look back at April 2020 to the end of March 2021. So it's inevitably looking at that key period around sort of COVID. There's a lot we did. And, if you want to know all the detail, you have to read the report itself. There's no getting around that. And I recommend that document and the quality account if you really want to know what Berkshire Healthcare did over that 12-month period. My presentation, which I'm using at the AGM, is literally a snapshot of some of the highlights of the year. It's no more than that. There's no way I could capture it all. And clearly, it's got a COVID theme. So I don't know, Julie, are we able to show the presentation? Are we able to get that up?
Yeah, Linda's going to share her screen.
Ah, lovely. Yeah. So I'm just going to run through the slide. The first slide is not really for you, but I'm using the same one at the AGM. So the next slide, it just tells you a little bit about the trust. And the reason why I do that is we often have a number of people at the AGM who get us confused with other organisations. So it's literally to tell people which organisation we are. So it just talks about the fact that we're the community mental health provider, our size, the fact that we're into integrated care systems, etc., etc. So useful for the general public. So I don't get questions about Heatherwood or other places that we don't run. The next slide is again has been covered off this morning, just to say that obviously we're very proud of our outstanding overall rating for the CQC, which we got just before the start of this year, and obviously very proud of our outstanding for well led. but there's not a single person in Berkshire Healthcare who is complacent or thinks we're perfect. But we have seen that as a springboard to make further improvements during the course of this year, and we do want to build upon that. So if we get into the next bit, is really about the pandemic. There's a lot of background noise. I don't know if people go, that's helpful, thank you. The pandemic, well, it was for everybody, I think, but particularly those involved in healthcare and in Berkshire Healthcare, a year like no other. It did bring the very best out of our colleagues, and we have to say a huge, huge thank you to all our staff over that 12 months. There's no other way to describe it. Our staff, both clinical and non-clinical, have given everything over the last year, and I emphasise that. So people like our procurement lead, who was responsible for effectively making sure we secured PPE, was working around the clock 7 kind of days a week, as well as a number of others. So obviously the television images often showed sort of clinical staff, but actually it was all of our staff who pulled together. I should also say during the first wave of the pandemic, a number of our community services were suspended and staff redeployed to those services which continue to operate. So for example, things like school nursing was suspended because schools were closed, children obviously less susceptible in the early wave to COVID, and those staff were moved to areas where there was often very high levels of COVID activity, for example, inpatient wards. And a number of them had never worked in settings like that before, so they did an unbelievable job in order, sole purpose here, of course, was to make sure we could deliver the very best care during the pandemic for our patients. And the dedication, hard work and resilience of those folk has been quite remarkable, really. Next slide, please. One of the things that is so important, I think, in terms of patient safety has been the sort of the PPE angle on things. So keeping everybody safe, so that's patients, our staff and our families, has been really, really important. And Debbie, our chief nurse, has made sure, along with Minu, our medical director, that infection prevention control guidance has been followed rigorously. Obviously, it changed during the course of the pandemic, but making sure staff used and continue to use appropriate PPE. We've adapted our services so that we're able to offer patients a choice so that they don't have to come in to the office. And we've now got pretty much a blended model, but we've moved from a few hundred online consultations a month to about 8,000 now. We've settled down now. And we were really helped by that. During the course of this year, we were actually awarded Global Digital Exemplar status. So we've been working on that programme like a number of organisations, about 12 nationally out of 250 trusts. But we were the first mental health and community trust to actually complete the programme. And that really enabled us, that digital expertise, to be able to do some of the things that we've been able to do. And that ability to utilise technology has helped us safeguard our patients and our staff also by allowing those who can work from home to be able to do so. Next slide, please. And again, sort of key part of keeping patients and staff safe has been the vaccination programme. And Heidi, who was just speaking to you then, has obviously been one of the pivotal figures in terms of that. But in December 2020, we were selected to support the rollout of the national COVID vaccination programme. So some trusts did this, others didn't. And the team were amazing, administered over a very short order 36,000 doses of vaccine. And that was to all staff and staff from health and social care partners. So we did our own staff, but we went much beyond that. So into care homes and social care staff as well. And the team and the experience of the vaccination clinic was fantastically positive. Next slide, please. So as part of the pandemic response, one of the things that we really focused on for patients was delivering joined up care. And a good example of that has been the rapid community discharge service that was established by the NHS and local authority colleagues to make sure that people didn't spend longer than necessary in an acute or community hospital setting. So making sure actually there was timely discharge from hospital. And that has worked fantastically well. And to be clear, around 90% of people involved in that rapid community discharge have gone from hospital to home. That's quite incredible, really, where most people want to be. So it made a real difference. That service still operating now, 7 days a week, included much bigger expanded discharge teams to cover the weekend and out of hours, simplified funding for onward care, which has really helped. So actually people move directly and the care and the funding is sorted out afterwards. Dedicated transport 7 days a week, and intensive therapy, particularly on our wards, on our community hospital wards. The therapy that previously was commissioned was only 5 days a week. It will move to 7 days a week intensive therapy on the wards, and that's made a huge difference. And we've also seen through similar measures a significant reduction in delayed transfers of care in our mental health wards from 7% to just over 4%. So real big benefits for patients during the course of the pandemic, and their programs of work we hope to continue with in the future. Next slide, please. We inevitably, given the Herculean effort of our staff, have done a lot to support them. We had a number of things in place before, but we've set up dedicated psychological support service for all our staff called our Wellbeing Hub. But Berkshire Healthcare provides that Wellbeing Hub to all health and social care staff in the area. So we're supporting local authority staff, care home staff as well, with dedicated high quality psychological support, because some of what people have witnessed has been very traumatic, and certainly even at the lower end, extremely difficult and stressful at times. In the National NHS Staff Survey that was completed during the course of this year that we're looking at, we came top in the sector for staff engagement, and that's measured by satisfaction, motivation and pride in the organisation. So, pride in the organisation. Would you recommend this as a place to work to your family and friends? Would you recommend it as a place to be treated? Satisfaction and motivation, perhaps slightly easier to understand. However, we recognise, and despite that top rating, we recognise we have much more to do with regard to the experience around race, disability and sexual orientation of our staff, where satisfaction levels are not as high as their counterparts. Final couple of slides, please. Next slide. Just a huge thank you. Probably one of the things that stands out about that 12 months under review that I've never experienced before in my career is the level of support we had from the public, communities, businesses and individuals. So, we had sight of, Harrods lorries arriving at Woking Hospital. We had people donating generously. We had local residents cooking food and bringing it in for the staff with enormous measures of support, compassion, and frankly generous donations, which were actually at times just overwhelming. And that was one of the highlights, I guess, of the last 12 months about how it brought everybody together and the level of support for sort of colleagues. So that, in a nutshell, is just a high-level take of some of the things that happened during that last sort of 12 months of the financial year, the last financial year in effect. I believe Paul has now got a few just slides to summarise the financial position. Is that right, Paul? Paul, are you with us, and do you have some slides?
Yes, and I do.
No. So I hopefully kept that simple. Hopefully Paul will, just to give us a flavour. And again, at the AGM, it's a statutory requirement that we report on the financial position of the organisation. Again, it's high level. We don't try and bamboozle folk. If you want the detail, you have to go to the annual review.
Thank you, Julian. Just have the next slide, please, Linda. Hi. So obviously the financial reporting and the financial regime for 2021 was substantially altered in terms of our response to the COVID pandemic. So in March 20, the normal annual planning cycle that the NHS would follow was suspended. And this allowed all available resources to be pushed into responding to the pandemic. We operated under a revised financial regime for the whole of 2021, with assurances that effectively that the costs of fighting the pandemic would be met and that organisations wouldn't be exposed financially as a result. So to this end, we had a commitment that the additional costs that we incurred in terms of responding to the pandemic would be met. We received further additional funding to ensure that the trust was able to achieve a minimum of break even over the course of 2021. And obviously changes in expenditure patterns, so significant increase in requirement for PPE this moved to a model where the vast majority was centrally procured and funded, taking the pressure off the organisation. And for organisations where potentially there was a cash or liquidity problem, the payments and timing from our commissioners under our contracts was amended so that some of that cash was brought forward so that trusts didn't run into liquidity problems. And obviously, one of the key elements of financial planning is the annual efficiency programs. These were suspended for 2021 again, so that everyone could be focused on dealing with the pandemic. Next slide, please. So in terms of the headline numbers, for 2021, we returned a surplus of 900,000, which was on a par with the surplus that was achieved in 1920. You'll note both our income and expenditure increased substantially, so 25 million plus increases in both income and expenditure. Within that increase, that accommodates the costs and the funding that we received in relation to COVID. So just to put that into context, we've estimated the additional marginal costs. So these are the additional costs over and above what we would normally incur in terms of specific pandemic response were just over 10 million, so 10.5 million. And in addition to that, our PPE procurement was 2.2 million. And that's an increase from a normal year where we'd spend probably no more than 100,000 to 200,000. So what did we spend those additional costs on? So additional staffing, covering sickness, purchase of additional equipment, adaptation to our buildings to accommodate social distancing and infection prevention measures, additional equipment and infrastructure to allow huge swathes of our workforce to work from home as well are also included in those additional costs. In terms of the rest of the increases, those would be the usual inflationary increases that we would see to non-pay purchases and pay costs, as well as funded investments from our commissioners. And that was things like, as Julian alluded to, the increase around the rapid community discharge service and continued mental health investment that we got from commissioners. Despite everything and despite all of the challenges, we still managed to invest 8.5 million of capital investment during the year. So some notable investments included the movement of learning disabilities to Jasmine Ward at Prospect Park and completion of our early house development on Reading University campus, as well as our continued investment into our IT infrastructure, including equipment refresh for a number of staff. And we closed the year with 39 million of cash, which was a 12.7 increase on the balance at the beginning of the year, which included some elements of funding received at the end of the year, which we anticipate utilising in 21-22. And obviously, as Chris has said, despite everything, another unqualified audit opinion, which means yet another year with no material adjustments identified through our annual report, which was hugely welcome. Next slide, please. So if we look to 21-22, we are still operating under a COVID financial regime, so we're still planning almost on a six monthly cycle. We've planned for a break-even position for the first half of 21-22 and are on track to achieve that. We are still receiving financial support to cover the additional costs that we're incurring in response to COVID, and we're getting additional funding this year to try and alleviate some of the waiting list pressures that have built up in some of our services over the course of the last year. And we've got a plan this year to invest a further 7.9 million in capital. So again, a mix of investment in IT infrastructure and equipping, as well as buildings and estates maintenance and development. At the moment, we're about to receive guidance on the financial plans for the remainder of 21-22. Expect that we will still plan for a break even by the end of the year, and we don't expect all of the additional funding to be removed, but we do expect to see that additional funding start to reduce slightly as we go into the end of this financial year. Thank you.
Thanks, Paul. Thanks, Julian. Any questions, please? Andrew. Could we stop sharing the screen, Linda? Thank you. Andrew, you're on mute.
Thank you. On the performance report on page 87, lost it. Sorry, it's jumped away from me. Here we are. Page 87. The out of area placements have jumped enormously. Not surprisingly, though. Is this something that we expect to go down again? Or is it going to be an enduring problem?
Yes, so Martin, I think this we're on the performance report, so happy to take it as read and just take any questions.
That's fine. Just make sure everyone's. So we're going to bring item 8.2 in now. Assume it's read and take questions on those as well as Julian's and Paul's presentation.
Yeah. We'll take all comers. Yeah, yep. I'm very happy to do that. Yeah, the out of area placements definitely had a spike. Nationally, we've seen demand, Andrew, for adult mental health beds really rocket up. It has slowed down, and because of COVID as well, Andrew, we've had to close beds and admissions to beds. So we have contracted for a number of private beds, which are local and don't therefore not classified as sort of out of area. They're a permanent, substantive kind of number of beds where we can obviously have a regular interface point with them, and that has really helped. So I don't expect demand to go down, but also at the moment, for example, we've had to close 2 of the acute wards for admissions because there's been a number of cases spotted, 2 cases on each of the wards where there's COVID, so we're not taking any new admissions to those wards. So again, I think during the course of this next 5 or 6 months, we're going to see that periodically, hence why we've contracted for effectively a 5th acute ward to be able to provide some flexibility. So I think the demand has gone down slightly, but the operating circumstances, particularly around COVID, have also added an additional complication, Andrew.
Yes, thought so. Thank you. On the following page, the cardiometabolic sequin is performing much less well than I've expected. And this is something that's really quite important. It's a measure of the patient's physical health, which is often a function of their medication. Getting their blood pressure, smoking status, body mass index, and so on should be fairly straightforward, part of any admission to a ward, I would have thought. But the figures are really very low, apart from the intervention and psychosis service.
Yeah, I agree. So the physical health care element is a key focus for us, and this is running slightly behind. So the most recent figures, Andrew, show a significant improvement. We've appointed a number of leads in this area to help sort of drive this forward, both not just on admission, but regardless of where people are appearing. In terms of that, it's often a recording issue as well as a doing issue, because there's quite a lot to sort of record, and again, making sure we're recording accurately is important. So I agree with you, hugely important. I mean, an intervention or a conversation around smoking, getting some baseline good health stuff so we can intervene early, have some conversations, making every contact count around physical health care can really address the terrible inequality that people with serious mental illness still face around premature mortality. So Rose, I'm on the same page, but I'm pleased to say, and I'm confident we'll be able to show quite significant amounts of improvement over the coming quarters, Andrew. So don't take my word for it. Next time, let's have a conversation about where we're doing in terms of physical health. And Martin, if we haven't already at some point, it would be good to get Kerry to come and present on the work we're doing around physical health. I don't know if she's done it previously, but it would be useful to have an update because we have got some quite significant amount of work going on as one of our driver metrics and breakthrough objectives. And it is interesting in terms of some of the stuff, particularly also, Andrew, making sure that people have the same access to their GP, where most people would have their physical health checks as well. So we normalise some of this stuff on an ongoing basis. So it's a bit more to follow, and hopefully perhaps we can do a little bit more in terms of detail on that physical health stuff as well, Andrew. If we can get Kerry along to maybe the one after, or the next 6 months or something, will be good.
Yeah. Thank you very much, Julian.
Thanks, Julian. Paul.
Yes, thanks, Martin. I'm focusing now on page 77 of the performance report, just for a bit of additional information. First of all, there's mention of another co-production initiative in East Berkshire, for which we've been given awards, and this is recurring again and again. They're doing really well with co-production in East Berkshire. Why does this not appear in West Berkshire? That's one question. And the second question is relating to this new well-being initiative, and I just wonder how this is funded, and if it's funded and staffed by the trust, or if it's commissioned, or because it seems that it goes wider than our trust in terms of target audience.
I'm sort of answering these questions from memory, but when you quoted your page numbers, Paul, that took me to the carers strategy, whereas you're looking at something else, aren't you?
Chief Executive
it's the first page of the performance report. Council.
The Chief Executive's highlight report, and the heading is local.
Okay. Yeah, I mean, there is differences between East and West. I mean, the auditor picked up on it that we're in 2 ICSs, and so the co-production work was done jointly with the CCG, who wanted to do that sort of piece of work. So you're right, there are differences, and we try and mitigate those where we can. But the creation, and as you'll see from the rest of the report, those 2 ICS boundaries have been confirmed as ongoing, and they have different priorities and different ways of working. So we will try and mitigate that. But if I'm absolutely honest with you, Paul, I think we'll see more differences over the coming years. The only way to mitigate that would have been to be one ICS, and the fact that we're in 2 will cause us to have some differences in the way things are done. There's no question about it.
I'd just like to add to that, because I did go to an early meeting for the remaking of the EUPD pathway, and that was in Woking, so it's for West Berkshire, Wokingham in West Berkshire, and there was a team who had done some similar work in East, and they were there purposely to coach the people in West Berkshire about how to do co-production, yet it hasn't happened. And that's my concern. It's not really about the commissioning, it's about our way of working and way of developing new services.
Oh, okay. So in relation to the personality disorder pathway, that was a Berkshire-wide piece of work that was co-produced, but that was Berkshire Healthcare, if you like, doing that on its own, as opposed to it being a commissioned piece of work. So the personality disorder pathway that Minu has spoken to us about had service users from across the board involved in that, and still does. And there are service user networks now operating in all of the localities called SUN, Service User Network. And so there is definitely that going on. It's easier, Paul, when it's a service redesign, if you like, an internal one that's contained within Berkshire Healthcare. It becomes more difficult when we've got others. You asked another question and I've forgotten it now, Paul. Sorry.
Yeah, the new Wellbeing Matters website. I just wondered, because this is directed at a wider audience than our employees, who operates that and how it's funded.
Yeah, we operate that, and we get funding central. It's relatively small to cover the cost of that. But that is the bit I was talking about in my presentation, which is about offering support, and we are paid to do this, to build up our psychological support to support staff across health and social care. So that's part of the publicity of it. It's part of you can see resource materials on it. It makes it easy to contact the team for support. And so if you're health and social care, providing health and social care in our area, you can use and access that support. And so we got some additional resources in for it, Paul. We bid to be a sort of a hub, if you like.
Okay, good, thank you.
Paul, just before I invite Guy, the issue of East and West Berkshire is one that, you know, we're constantly worrying about. We recognise we're in 2 ICSs, but we don't want to have unnecessary variation, unnecessary differences. So trying to get a common approach to things, I think, is part of the theme going forwards. But, you know, we don't control all of that ourselves. Guy.
Thank you. Page 80 of the pack shows a number of assaults on staff. It looks to be the highest I've ever known, as 170 for the quarter. It seems that the measures we're taking to reduce assaults don't seem to make much difference. So I'm wondering, is there a way that we can at least mitigate the harm caused to the staff?
Yeah, I mean, it does fluctuate. I mean, we were talking about assaults to staff this Monday in our quality executive, where it's a sort of a driver metrics, a real focus of that. I mean, the reality of it is, Guy, is that it's often a small number of patients who are performing multiple assaults. Of those assaults, there are 100 odd, way too many, but the vast majority of those are at the lower end. So we've certainly mitigated the more serious incidents. So I'm not so sure that all our efforts are in vain. And I suspect it's going to be extremely difficult to eliminate such behaviours, particularly where you're bringing people in handcuffed by the police in 136 suites because they've been sort of aggressive and violent, and suddenly they're going to change. But I think, you know, the thing that we're doing is continuing to involve staff and patients in those violence reduction programs. And I think the thing that we've most learned over the last few years on this, Guy, is that whilst there are some generic environmental things and generic process things that wind people up, and if you get them right, it can help calm the atmosphere, there tends to be a number of things that you have to do that are bespoke to that individual patient. And sometimes that takes a few days or a few weeks to understand what those additional personalised triggers are, as opposed to the sort of general ones. And that's probably where the challenge around this work is, because we've done quite a lot of the changes to ward regimes, ward environments, because we've had feedback about those things that are actually unhelpful in terms of violence and aggression. But sometimes the triggers of one individual can be very different to another. And I think normally it's the time lag for the ward to be able to work out how they can best manage that individual. So it is of great concern to us. It's a horrible thing to happen at work, but it continues to be a focus, and I suspect it will be for some time to come.
Thank you.
Julia.
Thanks, Martin. I just wanted to offer some clarification on page 77, which is page 2 of the performance report. So bottom bullet point is talking about the government mandate for NHS staff who work in care homes to have the COVID vaccine. And the last sentence states that we sent a letter out to staff explaining that we'll be accessing their vaccine records. We didn't do that. We didn't access staff's vaccine records, and we didn't send a letter out to them saying that we would be doing that. We found out the vaccine information in a different way, because that would have all sorts of implications from a consent perspective. We shouldn't be accessing staff's medical records. So I just wanted to clarify that.
Yeah, thank you. That is correct. And sorry, Julie had asked me to cover that off, but obviously we went into the performance report before I had a chance to do that. That is correct. And on that note, we've now we had about 120 odd members of staff who either regularly or occasionally were going into nursing homes, and I think it's about 11 or 12 now are outstanding in terms of probably not wanting to be vaccinated. Of those 11 or 12, most of those, if not all, are not high visitors to those homes, and Debbie thinks we can find ways of mitigating that in terms of alternative tasks, roles, and everything else. Of course, there is the much wider consultation that's going through at the moment, which is about the whole of the health and social care workforce around both flu and COVID, which, if it was to come about, it will be slightly more difficult to mitigate than this particular issue. That consultation is ongoing, and I'm sure Debbie and Julia, in terms of her union role, are exercising their minds now about how we can best keep patients, staff safe, whilst allowing people to make individual choices.
Thank you, Julian.
Thank you, Julia. John Wellham, then Tom Lake.
Julian, can I quickly take you back to your response to Guy? Is there an established system for learning from this 4 days, week, 2 weeks on how to have a good bespoke response?
Tom, was that about assaults on staff?
Yes, it was, yeah.
Okay.
Yeah, sorry, it was me trying to unmute myself, Martin, sorry.
Oh, sorry.
And the delay. So, yes, there is. So, all the members of staff working on this are trained up in the science of quality improvement. They're looking at their data on a day-to-day basis. They're looking at where the assaults happened, the nature of the assault, what the triggers were, what the things that happened beforehand. So, and obviously having conversations with patients and colleagues to try and work that through. But, modifying people's behaviour is much easier said than done, particularly perhaps if people are acting through serious mental illness, acting on voices, all those types of things. They can be quite difficult to modify, change and adapt very quickly. So yes, I'm confident that people have the tools. I just think it's a very difficult thing to do. The point that the Trust is making is actually one assault is too many. It sucks the joy out of work. Last year, there were 79,000 members of NHS staff officially assaulted. It's much more than that. And of that, 2/3 of them worked in organisations providing mental health and learning disability care. So our sector is the issue where the majority of physical assaults are happening. So for us, it's top priority. And yes, staff have got the tools, but it's just not easy. But it won't stop us.
Okay, Tom, and then we better move on.
Yes, just to say that Ros Crowder and I made an in-person visit, governor's visit, QA visit to Sorrel Ward, the psychiatric intensive care unit, and spent some time there. It was very interesting and a good visit, and our report is available. But want to say that we were told that one of the triggers is where patients have planned activities where they have to be accompanied by a member of staff. So it might be going out and leaving the hospital or doing something else, something in the hospital. And then because of a sudden demand, there might be to accompany a patient to the Royal Berks or something like that. The member of staff has to be diverted, and then the patient is frustrated, and this sometimes leads to these assaults. So just to say, it is partly a consequence in that case, if that's correct, of staff shortages and just the, of course, the pandemic would have played a role as well. Anyway, just thought I'd put in what we'd learned in our visit. Thank you.
Tom, thank you very much. Well, thank you, Julian. Thank you, Paul. We better move on. Item 7 is steering group reports. Could I just ask at the colleagues who speak to us to keep it fairly short, because we've got the carer strategy presentation that I'm keen we hear from Katie. So John Barrett's not here, so I don't know who's going to speak to Living Life to the Full. Anyone? No? Okay. So we do membership and public engagement, Tom?
Okay, well, our membership is doing well, but as what we learn when we look at it closely is that the number of members is going down slightly in our constituencies, but is rising in the rest of England. And I think partly we do have patients from South Oxfordshire and Hampshire and so on. And also we sign up all sorts of people who come to Reading Pride and any other public events that we take part in. So, and there was certainly there were lots of people signed up at Reading Pride this year. The stand was very popular and loads of people in there. And so that's the balance of what we've seen. So we're certainly not taking sort of positive action to improve the balance between the different constituencies. So that's as far as membership goes. We've had in the committee, I've certainly had an insight in that there are certain services that are very strong in public engagement. One of them is the school nurses. They do a lot of public engagement work with their public, which are the children and young people. And we've had we had a very interesting presentation from Beverly Wheeler, and then which shows that how they do this work, and they've got young people making videos for them and things like this. And I think this is an element of participation which we could build on. And Councillor Deb Edwards also referred me to the Young Ambassadors programme at number 5, the counselling charity in Reading, and they have got young people doing outreach work, perhaps people who've used the service, and they've built on that to involve them in decision making in the charity. So that is, and I think that's the right way to go. The key thing I think we've learned is that getting involved in practical activities first and then in decision making is the right way, certainly for younger people. And Beverly Wheeler told us that conventional membership really wouldn't be of much interest to most of the young people she sees. So I think that's where we are. It gives us somewhere to go from. We hope to hear from Talking Therapies in the coming months in membership and public engagement, because that's they also have strong public engagement because they use self-referral. So we'll continue with that line, I think, and invite people to join with us and follow that line of discussion. Thank you.
Thanks, Tom. Andrew, quality assurance meeting, anything you want to pick up?
It's possible, if Andrew's left, which he said he'd had to leave about 11.
Right, okay.
He asked me just to say a few words.
Please, Tom.
We had a very good meeting in which we heard a report on CAMS, a strong report on developments in CAMS, and then we looked at the material we get. I'd invite anyone who wants to get a more detailed view of the trust among the governors to join the quality assurance group. It really is excellent. We get a very detailed report now on waiting times, which is really helpful, and we can see where things are going out of kilter and so on. Now, we know that there are certain elements of the specialist elements in CAMS, autism and ADHD and so on, assessments for diagnosis. These have had very long waiting lists. And in that area, these have now been transferred out of CAMS directly to a new neurodiversity section, and are being handled there. And we hope that investment there is going to reduce those waiting lists substantially. But for the main body of work, there is also considerable investment, we heard, and I think this was very encouraging, that there is real investment going on, and provided that the staff can be hired recruited to, of course there's a national shortage, but if we can recruit the staff to fill the places, then this waiting times are going to come down again. So the waiting times for first assessment in the common point of entry and then later. So there's a lot more in our minutes and in the papers for QA, and I invite anyone who's interested to get in touch with Andrew Horn or through Jennifer Knowles, and really to attend the group. We get really excellent presentations and information about services there. Thank you.
Tom, thank you for doing that. And I attended the meeting myself, the last one. It's very interesting. It's very good. Okay, I think if we may, we'll move on, because we have a presentation on carer strategy from Katie Humphreys, who is the new carers lead. Katie, are you there?
I am here. Hello. Thank
Katie,
you.
can we hand over to you, and then and I think you've got a request to governors at the end.
Yes, I do. I will. Oh, I've not. This is very. I thought I was going to share my own slide. So sorry. That's what's thrown me. I had them all set up beside me. Okay. So thank you for inviting me today. So this is a short update on the carer strategy, and you'll notice at the right-hand side there that actually we are trying to extend that definition slightly to badge ourselves as friends, family, and carers, because often carers don't identify themselves as such and prefer to be considered the son, daughter, husband, wife, etc. We're also aware that there's no such thing as a typical carer, and that you may become a carer overnight, and it's very unique to your personal experience for everybody. So what we're trying to do is look at best practice and identify the areas that we concentrate based on that sort of information and data, and that we'll get that voice of carers from each service as we develop things in time. So if you could go to the next slide, please. The content of the presentation will be a little bit of information about the impact of COVID-19 on carers, and an overview of the carer strategy, which consists of 6 standards. And then I want to go through what we've achieved so far and what's in development, and a quick summary of our roadmap for the future. So next slide, sorry. What we can see here is that Carers UK Carers Week research report shows that a number of unpaid carers increased enormously during COVID, that we've got up to 13.6 million people potentially providing unpaid care in the UK today. And actually, it's important, I should have stressed at the beginning, when we're talking about carers and friends, family and carers, it's in the unpaid role. We also know that in the long-term plan, there's a disproportionate impact on communities most likely to suffer from health inequalities as a result of COVID-19. Carers are often providing an additional 10 hours of care a week. So all those statistics there that I'm hoping are flicking up as we go through, because there was some transitions on there, that shows the increase, particularly in the new carers and potentially the younger carers or working carers that are COVID's impacted on us all. Next slide, please. This information from the Office of National Statistics also illustrates that the groups that are caring have potentially changed, and as well, so that this will potentially identify areas for future work streams in the future. So recruitment and retention could be an area, because we're seeing that actually there's a lot more working carers having to juggle responsibilities. So potentially we don't want to lose any staff, so that might be something we look at. And also some of our BAME communities might have a higher caring responsibilities, so we might include that as some of our equality, diversity and inclusion work. Sorry, next slide, please. So about well, I was going to say about a year ago, but of course I forget that COVID's been in there. So probably 2 years ago, we forget that year, don't we? In 2019, there was a workshop that looked at what our carer strategy should be, and we decided that there should be a defined offer of care that was informed, understood and valued by carers, and that actually we should try to offer this across all our services, and that we'd regularly review that offer, and that there should be some form of compliance through a self-assessment. So the group that looked at that, there was a workshop, and we used our QMIS principles to engage with carers and service managers to come up with the strategy. And it also was based on the Triangle of Care, National Guidance and Best Practice. So we've identified 6 standards that are in align with the direction of travel for NHS England and improvement, and also link with the strategies for the 6 local authorities in Berkshire, and also map to the NICE guidance. Next slide, please. So for us, these 6 standards that we've come up with for the strategy are split into 2 tiers. We recognise that across the different services, we've actually got a myriad of services, so their engagement with carers could vary enormously. So what we wanted to do is identify services within tiers, and if you're a tier 1 service, then you would have the generic offer to carers where you would have staff that were carer aware. They would identify carers and involve them in the planning of care, and that we would be able to signpost carers to relevant support. But if you were identified as a tier 2 service, then actually you'd have to meet all 6 standards, so that services would have allocated members of staff responsible for carers. They would provide information across the care pathway, and actually we'd get that data and feedback from carers on how they saw the services and what they wanted them to do. So what we've done is we've set up a friends and family steering group to identify the priorities that we should be working on. So next slide, please. And as part of that work stream, the recommendation was also that there was a carers lead appointed. So I started in post in May. So what you're seeing now as to what's been achieved and what's in development is what we've managed to put in place since May. So obviously it's still quite early stages, but we're moving things forward. So I've been engaging a lot with our integrated care system partners and also some of our national partners in NHS, E&I, with the Frimley ICS carers lead. There's also a Triangle of Care national group that's been reinvigorated, and I've also attended several of the local authority carers steering groups. So that's in Woking and West Berkshire, Reading and Slough. Bracknell and Royal Borough of Windsor and Maidenhead are currently recruiting to carers leads posts, so they aren't offering any strategy groups at the moment, but we are linked in with them. So as I mentioned, we've set up a friends and family carers steering group that are hopefully identifying the way forward and the work that we want to address and try and support services to hit those standards. So we've got carer representation on that group already, but as Martin mentioned at the beginning, what we're hoping to do is also have a governor represented on that group. So we'll be looking for volunteers to join if this is an area that you feel that you could would like to get involved with. So at the moment we're meeting every 8 weeks. We've just had the second meeting this morning, and we are working on work streams, setting up task and finish groups. So next slide, please. We are identifying these key priorities, and if you click again, the graphic should come up about what the priorities are, and having these task and finish groups and action plans in place so that we can make sure we're really keeping a track of the progress against each priority. So next slide, please. We've achieved step 1, as I say, so far. We've also got representation in that steering group from across the divisions. But one of the key things we wanted to do was understand what's happening at the moment in each of the services and see how we can identify services falling into tier 1 or tier 2. So we've created a baseline evaluation form that I've been attending the PPSQ, the performance meetings across all of the divisions and localities, to share this form with them that each heads of service will complete, and we'll get data back on exactly their carer activities at the moment, what their offer is, and then we're hoping to plot that information against a matrix to identify if they fall into tier 1 or tier 2 services. I don't feel that actually it's as distinguished as tier 1 and tier 2. So you might have some services that will kind of hit be able to achieve all the first 3 standards and be at tier 1, but actually they maybe should be working towards tier 2 services in the future because of the nature of the engagement that they have with their carers. And so step 3, as I say, we're trying to identify task and finish groups of what we can work on at the moment, but once we get the information back from the evaluation, we'll be analysing that, and that might change some of the things that we want to work on. So next slide, please. I'll go into a bit more detail about some of the priorities that we're working on at the moment. So the first thing that we want to do, which links to the first 3 standards, is to create some care awareness training, because we can't expect services to have staff that are care aware if we don't put those foundations in place to help them do that. So we're developing some e-learning, and we'll hope to have that finished by November or December at the latest. And we'll also have some face-to-face training that can be a bit more in-depth for people, and we'll hopefully have some carers' voices in that, and maybe some videos in the future. Nexus has come up as a question there. Nexus is our internal intranet. So one of the other things that we want to do is linking to those signposting is making sure that information is up to date on both our external website and our internal web intranet. So what we've done is we've initially made some changes to the website to make sure that it's up to date and accurate. I've included some things in there about frequently asked questions or some extra information that carers might want to access. But we've got more work in progress in relation to the website, and in relation to the intranet, we're hoping to add resources that different services could tap into. They might see something from another service that they think is good practice and they could adapt it themselves. So rather than reinventing the wheel, we want to adapt and adopt where possible. Again, one of the feedback from carers is often about issues about confidentiality and what information can be shared and can't be shared. So we're hoping to refresh some of the marketing communications about that, and maybe introduce things like a newsletter for staff, perhaps on some of the best practice, and to showcase some of the good work that goes on in services to share across the different areas. And linked to that is also about recording and reporting, because at the moment there's a myriad of ways that you can actually record things on our Rio systems, and what we're hoping to do is have a group that's looking at that to try and establish some consistency and some standard works using our QMIS methodology, so that there's a bit more consistency and standardization. And we'll then also be reporting regularly to QPEG and QUAC. I get that wrong every time, or there's an acronyms. Next slide, please. So linking to the standards 4, 5 and 6, as I say, one of the key things is this baseline evaluation that we're sending out to identify the carers, leads and champions in different services, so that we can work more closely with them on some of the activities that they are rolling out. I also want to engage more with the carers about the feedback. So we're looking to digitalise the friends and family form and put that on the website, because currently carers' feedback is excluded from the first iteration of the I Want Great Care project, but would hopefully maybe make some inroads into that in the future. And we want to look towards some co-production and involvement with carers. So we've just been discussing this morning in the Friends and Family Steering Group about potentially having a carers charter. So that's something I'd like to progress, as a lot of organisations have that, really our commitments to carers and their commitments to us. And then finally, looking at any funding that's available. So an example of that we've managed to do so far is to work with NHS England and Improvement, and we've got £10,000 funding to support a piece of work to get feedback from carers, specifically with the veteran services, about what they need and if they've got different requirements. We have obviously within the bid put what we think the outcomes and the outputs of that might be, but we didn't want to be too explicit, so that actually the outputs come from the carers' feedback themselves. And another area that we're particularly keen to look at is about working carers in the NHS. NHS Improvement estimates that it's about 250,000 NHS staff are actually carers themselves, and that with COVID, those figures have probably increased. It's also likely that that's your more mature workforce, potentially over 50, who may be a long-serving member of staff. So actually understanding their needs and working with them on that is something that I'm keen to look at. And I sit on the Purple Network that looks at supports carers as well as the staff with long-term conditions and disabilities. So I'm hoping that that's a piece of work that we can do in the future. Next slide, please. So our little roadmap to for the first year is setting up the Friends and Family Carers Group, creating this baseline evaluation, introducing measures that we hope will support services meet those first 3 standards, such as the awareness training. October to December really is the next targets, is analysing that data that we're going to get back from the evaluation, identifying which services fall into tier 1 and tier 2, feeding back to them and working with them on what that looks like and how we can support them move forward, launching the carer awareness training, and then based on information, hopefully roll out some of the self-assessment processes in January to March next year, and setting some of the priorities for year 2 based on those findings. And actually I've also linked in through the Triangle of Care with some other NHS organisations who are looking to digitalise some of that self-assessment processes. So perhaps we can also learn from other trusts what they've done in that space in relation to the Triangle of Care self-assessments, and maybe use some of that learning to help influence how we roll that out in the future. Next slide, please. I think it's just any questions, really.
Katie, thank you very much. Most interesting presentation. Governors, any questions for Katie, please? Because I know carers is an issue which comes up fairly often. Paul.
Thanks, Katie. This is great. We're so pleased to see more detail hung on this this initiative, which I know has been bumping along for a long time. But a couple of points that I'd like to be involved with a little bit personally is this. I'd like to look at, I mean, will governors have an opportunity to look at the e-learning material, just to check it from a sense point of view as far as carer governors? You say that's going to be available at the end of November.
Yeah, so we're currently working on the content. We've got members from the steering group commenting on it, and so I'm sure we could share more broadly and get extra feedback. Yeah, there is some issues about actually how you access that, but what we've done is like recorded it, and we could have a session. But yes, definitely. So if that's something you're particularly keen to get involved in, I can co-opt you into the task and finish group if that's something that
would be very useful. And I'm also very interested in the baseline assessment, the differentiation between services that fit in tier 1 and tier 2, because I think for us that are carers, there's obviously a big difference between what the trust puts into tier 2 compared to tier 1.
So at the moment, I'm only just initially getting some of the feedback back. What I wanted to do is apply some logic to how we're allocating those tier 1s and tier 2. So there's a couple of questions particularly that relate to that. It is slightly subjective, as it's going to be, because it's asking questions like the level of engagement, if it's kind of mild, moderate or intense, and the type of engagement and the amount of engagement. So it's slightly subjective as to who's filling the form in, but it's better than nothing. So that's what we're trying to do at the moment, and then I'm just going to plot that.
Because one of the things we say in these governor meetings is, you know, by your engagement with carers, you're actually multiplying the effectiveness of the effort of the service therapists.
Yeah.
And, so, you know, there's potentially tremendous benefit to our patients and service users.
Yeah.
So yes, I'll be pleased to be kept in some loop.
So maybe in the next time, if I feedback in the future, I can share some of the data that I got back and maybe some of the analysis of how it was allocated in the future.
Yeah, thank you.
Thank you, Paul. And there were a couple of hands that came up. Verity, did you have your hand up?
Yeah, I did. I mean, part of what I was going to say is all been covered before, but okay. It's great to see us progressing, because I know in the past and it's great to see you're actually attempting to engage with the diversity of carers and the level of involvement that people have, because I have pointed out many times in the past, especially among the community of people with mental health issues, the vast amount of caring that is done by one person with a mental health issue for another, from caring for partners to actually people who don't see themselves as carers, who are just doing it because it's a friend. And it can very easily slide over into people taking on a great deal of work, which then has an impact on their own mental health. I was interested that in the breakdown of statistics, there wasn't actually a graph for the number of people with disabilities who are actually caring. I think that might be quite an alarming statistic. but yeah, it's great that we're making progress.
Okay, thank you. A couple of hands. Madeline?
Thank you. Delighted to see the model and the roadmap forward. I'm already doing quite a lot of work in Bratton Forest with carers groups and giving sort of social support to those groups. And I'm particularly interested in looking at both the e-learning and the access to the carers' opinions, because it is so difficult to actually gather and collate what it is that is most helpful to giving the carers the support they need.
So that is a challenge, Madeline. So one of the things I was thinking of doing or hoping to introduce is potentially a register of carers, because often it's also that we don't know who and how to contact people. So I was wondering if I would create some kind of form or expression of interest so that we could actually have people on a register that at various points in time, you could then go back to them and say, would you be able to engage with, you know, X, Y, Z activity, and then hopefully get them involved at the right time. So, for example, I'm going to attend one of the recovery colleges putting on an event for World Mental Health Day, and then I was going to ask people if that was something to start the ball rolling on getting some kind of register of carer, so that in the future we can keep that up to date. So different services have people that they connect with, but I think sometimes you then end up hearing the same voice again and again and again, and actually is that breadth that we want to get as well. So that's what I'm thinking of doing, if that sounds like a good idea, hopefully.
It sounds quite promising, yes, and I would love to be involved with it.
Perfect.
So across the spectrum.
So I've got Madeline and Paul down there as my volunteers to join any of the groups, and is that okay? Any other volunteers?
They're all quiet now, Katie, because I know they're going to be picked on.
There is one hand up, Martin, still.
Oh, I'm sorry, John. Thank you.
Right, I might have missed this because unfortunately I had a Microsoft moment which threw me totally out. Paul touched on it almost at the end of what he was saying. Is there effectively a mission statement? So we've been very impressed by the strategy over the 2 years, but can you summarize in one short sentence the one objective that will say we have achieved what we set out to achieve?
I can, she says. I'm just trying to find it. I've got it written down nice and succinctly. So it's that all Berkshire healthcare services will have a defined carer offer, which is informed, understood and valued by carers. But I think it is about taking that little bit further and coming up with some kind of carers charter. So that's what I'd like to see as a key piece of work that we do, which is our commitment then to carers, and carers' commitment to the organisation. So for example, Royal Berkshire have got something that they've developed, and you link it to your organisational values, and it's quite a common sort of starting point. But I see that really as the backbone to it all. If we can come up with a carers charter that we're committed to, then everything else should fall from that, I think.
Okay, Tom,
that's great. Thanks a lot.
Thanks, John. Just a quick one because we need to move on. So.
Yeah, very briefly. I think it would be a good idea to circulate Katie's appeal to governors to those who are not here. I know that Ros Crowder may be interested, and I obviously don't know for certain, but it would be good to perhaps Jenny or Julie could circulate the appeal.
That's fine, Tom. Thank you very much, Katie. Thank you very much. You've clearly got a hot topic here, which governors. Not just governors actually, but governors, including the chair, are very interested in. So thank you very much and good luck. And I'm sure you'll get lots of input from governors going forward.
Thank you. Thank you for having me. Bye-bye.
Can we move on pretty quickly, please? We've got Julie's going to do appointment of lead and deputy lead governors.
Yeah, it's just to formally appoint Paul Miesco as the lead governor and John Wellham as the deputy lead governor.
Everyone content? Oh, someone's got a fancy hand coming up, Julia, I see. I think that's that means yes. Now, Julia.
Got one fan.
Got one, yes. My computer is not showing me the rest of the agenda. Can you
Yeah, it's the governor feedback session. If any governors want to briefly feedback on anything that they've done.
Anything special?
Then it's any other business.
Any other business for anyone? Okay.
And then it's just another the dates of the next meetings. 4th of November, which is the joint trust board and council of governors meeting, and 1st of December, which is the formal council meeting.
Okay.
Sorry, Martin. That's just under any other business. Of course, governors are very interested in the ICSs and the progress of the development of organisations and potential public engagement with the ICSs. I just wonder if there's some timetable of, I imagine, chairs meetings. I mean, the organisation, the governance organisation, is probably the business of chairs rather than these lower level, service level meetings between trusts. And I wonder if we could just have a little bit of visibility about these high level meetings. The reason I ask now is this week I was contacted by the lead governor of Oxford Health, who has some ideas which are probably quite impractical in terms of forging a new engagement organisation. So I'd like to have be able to do a bit of horizon scanning from a governor's point of view about what's happening on the two of these ICSs without knowing any detail or anything, just what meetings are coming up.
Yeah, thank you, Paul. I think the meetings in the chairs meet in both ICSs tend to be informal rather than formal, but the big issue is that it's sort of been paused because of the legislation or upcoming legislation, if it's approved by Parliament, to set up ICSs formally, and the competition to appoint new chairs of the ICSs and new chief executives of the ICSs, which is ongoing at the moment. And I think, Paul, I mentioned to you that I've certainly met all the candidates for Bob and for Frimley as part of that process of, I'm not in the selection process, but I've met the candidates as part of sort of making them aware of what's going on. So I think until that process is concluded, and I think it's going to, Julian may know the exact dates, but it's going to be some time, I think, before we know, some weeks before we know the chair's appointments, and the chief executive appointments are sort of being touted now. So I think we're going to be some while before the top level posts are really in post and able to sort of do anything, and then they've got to stand up the organisation, and that's going to be a big job, and one where we need to be really heavily involved, because there's the danger of the ICSs is that they're sort of ill-defined in one sense. They've got some legal things that have to be happened, assuming legislation goes through, but there's a lot of variation that those chairs and chief executives can put in place. So I think we've really got a big period of uncertainty going forwards. I'm pleased to say on the ground, and Julian and I are at the Berkshire West Integrated Care Partnership, so it's a sort of a place bit of Bob, as it were, for Berkshire West, and trying to make sure that things keep going. But at the top level, until these senior appointments are in post, it's going to be very difficult to do very much.
So does this mean that David Clayton-Smith, who spoke at our governor's meeting, either the last one or the one before, is not going to remain as part of Bob?
Well, I don't know whether he will or not, but his post is being competed.
Right, okay.
As is Andrew Lloyd's at Frimley.
Yeah, okay, thank you.
All right. John?
This is an area which concerns me tremendously. I've been very impressed over the last year on how well the governance model has worked. And it's something that I hope that with Paul's help and your contribution, Martin, and listening to the rest of the governors, we can try to have a continuation of the same kind of governance model, so that we, the public, are a voice which is listened to, respected, and is an important voice.
Thanks, John. In terms of the trust, of course, you are governors of this trust and nothing changes in that respect. So it doesn't matter what they do with the ICSs, you are still governors of this trust, and so it's in your hands, as it were. It's the wide, I think Paul was referring, and I think maybe you were referring to the wider involvement in consultation on the ICSs. And I think we just have to wait and see how it's going to happen. There'll have to be some. I just don't, until the new chair and chief executive is in post, I think it's just guesswork.
Yeah, exactly. It is that wider presence that I think is essential, that is there and is there very visibly to individual trust governors, but actually the public at large.
Yeah, well, I'm afraid I can't foresee what's going to happen, but consultation is an essential part of the NHS. So, okay. Anything else? Any other business? Oh, a visit. Can I just say something about visits? I know that I think it was at the meeting, quality meeting we had on last Monday or something. People asked about visits, and I've spoken to Debbie Fulton, the Director of Nursing, and she is happy that governors' visits restart, but obviously we've got to all abide by the infection prevention control measures that the Trust has in place. And I think we just need to make sure we don't overburden staff in the Trust who are very busy with visits, just, in the way we'd normally do it. So I was going to ask if we could ask Julie perhaps just to sort of keep some central point of contact so that we don't all go and visit and get in the way of people whilst still allowing governors to have visibility of the Trust. So there's sort of a practical constraints there, but there's no sort of absolute bar on visits. So perhaps I can talk to Julie outside the meeting and we can do something more with that. Okay, Julie, you have to. I've lost all the papers are gone. They disappeared. So we're
formally ending this meeting, and then we're going to join the private meeting. So there's a separate meeting link for the private meeting now.
And could I just ask if there's a 5 or 10 minute break, because I've just got to try and sort out the computer, otherwise I am bereft of any information.
Should we start it at 12:30? The private meeting.
Is that all right for everybody? Okay, thank you. That'd be helpful. Okay. And I'll try and sort things out in between. Thank you very much, everyone.